So most of what we're going to do now is about pathophysiology. We're going to talk a little bit about renal failure, and then specifically proteinuria, and then we'll talk about aging and staging. So, case 5, Mr. and Mrs. Blake return home from a large meal. You've seen this one before, haven't you? Okay, but it was 4 weeks ago. Do you still remember this? You tested out, I know, yeah. This was a fellow with heart failure. He's got a blood pressure of 160 over 100 and a heart rate of 110. So, my rather straightforward little question, does Mr. Blake have renal failure? Well, okay, let me try to lead you down the garden path. His blood pressure is 160 over 100. Should be fine, right? Glomerular capillary pressure is just dandy. Come on, somebody argue with me. Something's wrong. Okay, I'll go with that. Anything will work. Yeah, he does have enough pressure to maintain filtration, but the flow's not getting there. And I don't care how much pressure you've got, if you don't have the flow, then you can't, you can't filter more than you receive. So clearly, Mr. Blake will be having trouble with proper filtration. I don't remember whether that was actually addressed in that case or not, but he won't be people with very severe heart failure lose their capacity to filter. So there's also another thing too. Not only is there low flow, but what's the response to heart failure? What's the main drive in heart failure?
Effective blood volume is really low.
Yeah, the effective blood volume is very, very low. But what does the body do to compensate? Yeah, sympathetic nervous system, right? So there's a general sympathetic drive, which is why the blood pressure went up. The cardiac output, theoretically it would increase, but it's an incompetent heart. But you also get some renal afferent constriction too, and that will contribute to a lowered PGC. Okay, renal failure, what is it? So I've got a definition here. Loss of renal function, either acute or chronic, and this is out of Stedman's dictionary, that results in azotemia, which Stedman misspelled, at least in my copy, and a syndrome of uremia. So really what renal failure means is an inability to maintain glomerular filtration rate. But the problem with these definitions, in 2012 we kind of scrapped the terminology renal failure, and I'll keep using it today, but the point is you can have quite profound kidney disease without a drop in GFR. And so you kind of, when you talk about renal failure, a person could be in dire straits with their kidneys, but the glomerular filtration is well maintained. And so in 2012, they totally renamed everything. And they talked about, instead of acute renal failure, it's now acute kidney injury. Acute kidney injury. AKI. And for a chronic condition, it's now chronic kidney disease. Okay. Now, in most cases, they're going to be accompanied by a loss in GFR, but not absolutely necessarily. So there's, and also the way we tackle these diseases now has changed a little bit. Many years ago, when I first started, the idea is, well, acute kidney disease is just that. It's acute. Fix it, everything's good. But it turns out that people that have episodes of acute kidney injury tend to be much more likely to have chronic kidney disease later on in life. And so there's a connection between, and it really shouldn't be much of a surprise, should it? The idea is once it was fixed, goodbye, go home, you're done. But now, you generally follow up an acute kidney injury by rechecking that person and make sure that they don't have any residual kidney disease. Okay? So what are the risk factors for chronic kidney disease after acute kidney injury? The severity of the acute kidney injury will increase the likelihood of chronic kidney disease. The duration of the acute kidney injury will increase the severity of chronic kidney disease. And also the number of times that you have an acute kidney injury will increase the likelihood of chronic kidney disease. So we've totally changed the way we look at this problem now. Acute kidney injury, monitor the patient afterwards. Okay, underneath that, progressive renal failure. And this is something that we should understand. So, if you have any kind of chronic kidney disease, you can stop it from progressing somewhat, but there is a tendency for it to progress. So what happens is, remember we got mechanisms to auto-regulate? Well, chronic kidney disease generally involves essentially the death of some nephrons. And of course, once a nephron's gone, it doesn't come back. So, okay, let me lose 10% of my nephrons, probably I already have, because I'm a couple of years older than you guys. So, assume I lose a bunch of nephrons, the others try to compensate. So, in order to maintain proper glomerular filtration rate, the remaining nephrons will tend to hyperfilter. It's called hyperfiltration. Surprise. That hyperfiltration is said to be an insult to the glomerulus. The increased glomerular pressure can cause further damage to the remaining nephrons and cause glomerular sclerosis. And that is why often kidney disease tends to be progressive. Because you lose some nephrons, it puts a strain on the others, and they're more likely to lose it, as it were. And so that is why, and you know very well in diabetes, one of the major problems in diabetes is kidney disease. In fact, I think the statistic is that in chronic kidney disease, 40% of them are due to diabetes. Okay, so kidney disease, diabetes is a major cause of kidney disease. And so, having given you that preamble, that's why we are so concerned we're seeing if we can find drugs that are renoprotective. Okay. If we can find drugs that are renoprotective, like converting enzyme inhibitors or ARBs, then we might be able to slow the progression of chronic kidney disease. So do you remember on Friday, how many people have chronic kidney disease in the US? 15%. Okay. At least that's the guesstimate. Actually, in 2014, it was considered 14.8. So, interesting that a lot of people don't actually know that they have chronic kidney disease. So just to fill out at the bottom of the page, end-stage renal disease is basically when your kidneys are functioning so poorly that you can't survive without some form of dialysis. Okay? So that's end-stage renal disease. And you know, I think it's worth saying at this point, if you go talk to people on the streets, they, oh, Mrs. Smith's got renal failure, she's got kidney disease, but she's okay, she's on dialysis. What do you think of that statement? Dialysis is not a magic bullet. Yeah, it'll keep you alive, but dialysis is horrible. It is terrible. People on dialysis remain very sick and they still have a very reduced life expectancy. So dialysis is not a magic bullet. You know, I suppose you could argue it's better than dying, but some people on dialysis would actually argue that. And I'm not trying to be insensitive, but it's tough. Okay, so let's flip, any questions? So let's flip the page. We're on page, doesn't have a number on it, but it's the next page. Let's talk about the types of renal failure. I think the diagram looks a little something like that. And there are ureters, and I'm just going to say that. Okay, so basically three types. Renal failure, now I'm using that antiquated term again. Reasons for losing your ability to maintain GFR. One is a problem before the kidney that reduces the pressure head, and we call that pre-renal failure. Remember the case we talked about? Anything that obstructs urine outflow, post-renal. And then all the rest that are actually something wrong with the kidney itself, intrinsic. So let's talk a little bit about pre-renal. We've essentially, this is where the glomerular capillary pressure has dropped. We cannot maintain enough pressure to maintain filtration. So what do the kidneys do? The kidneys, which are still actually healthy, try hard to correct the problem. And so if it's, for example, it's a dehydration, they'll try to retain fluid. Actually, no matter what it is, they'll probably try to retain fluid, which may not be a good thing in heart failure. Okay, so the kidney is working well. why do we then care about pre-renal failure? The reason is that although the kidneys work hard to retain the fluid, there is an issue. What happened with Mr. Good? The workshop that you haven't done yet?
Necrosis.
Hmm?
Didn't he have like necrosis?
Yeah, I think you know that he was dehydrated at the beginning, right? Or at least that was a good surmise. So he got dehydrated, and that led to acute tubular necrosis. I think most of you figured that out, right? So the renal ischemia that's caused, never mind the filtration, what the kidney's trying to do right. The kidney's very, very, very sensitive to renal ischemia, and so the dehydration likely led to acute tubular necrosis because of renal ischemia. So even though the kidneys are working fine, a surgeon post-operatively is very concerned about hydration levels because we know that it can lead to acute tubular necrosis. Let's go down. So further down the page, the kidneys respond identically to heart failure. And I think this is worth knowing because, and I've said it once, I'll probably say it again and again and again. So in heart failure, there is a reduced amount of blood flow to the kidney. The kidney sees this as a reduced amount of blood flow, and it says, ha, I'm not getting enough blood. The smart thing to do would be to retain some fluid. Make sense? And indeed, and that could well be good wisdom. So in the heart failure patient, the kidney retains fluid, but the heart's still incompetent, and so it still can't generate enough perfusion of the kidney, and the kidney says, well, didn't work. Let me try a little harder. It retains more fluid, retains more fluid, retains more fluid. It never has the effect that it needs because the heart is incompetent. The system wasn't designed to deal with an incompetent heart. And so that is why in heart failure you get continued retention of fluid, which the kidney thinks is a good idea. Of course, if there's not enough fluid getting to it, you need to bolster it, right? But it actually works against the patient. What's the outcome? What's the thing that really makes the patient die? In heart failure, what do they usually die of? Pulmonary edema, yeah. So look, this is very simple. If the heart can't pump the fluid, but you keep retaining more fluid, it ends up in the lungs. And the lungs that get waterlogged are really bad at gas exchange. And so inevitably, in this decompensated state of heart failure, the thing that'll get you is the fact that you can't oxygenate the blood or get rid of the CO2. Okay? It's worth spending some time on because for you guys as physicians, you will see a lot of people in heart failure. It's a very common disease. And understanding the process is very important. And that's why Mr. Blake got some, I bet you got some pretty massive diuretic treatment, right? Probably didn't help his cardiac output, but it helped his gas exchange. Okay. So, post-renal failure, at the bottom of the page, that was the case that we just went through. It's kind of important to recognize post-renal failure because usually it's an obstructive disease and usually it can be fixed. So what are the common forms of post-renal failure? Prostate in men, of course. That was the case, right, I think. What else? Kidney stones, yeah. Anything else? Basically any malignancy or any tumor that can impinge on the urinary system at any point. Okay, but I think prostate definitely the most significant. The prostate in males, I'm not going to say it always swells, but it's extremely common, and there's urinary retention is very common amongst older males. And when I get old, I'll have to worry about it too. Okay. Next page is intrinsic renal failure. I don't intend to say a lot about it. The pathologist will deal with this. I will say one thing. I've included vascular occlusion and stenosis, renal artery stenosis here. Some books will describe it as an intrinsic renal problem and some will describe it as a pre-renal problem. I don't really care to get involved in any such argument, okay? So understand these things for what they are. STEP exam likes to ask you questions about renal artery stenosis. So it's worth understanding what a renal artery stenosis can do. Okay. Let's flip the page. And we're on page 4 now, and we'll go through another case. I'll come back to renal failure a little bit later, but let's talk about proteins in the urine now. So the case. A 62-year-old man on no medications presents with ankle edema and recent onset hypertension. His physical exam shows no abnormalities except for 2+ pedal edema and blood pressure of 160/100. Urinalysis shows 3+ protein, which is a lot of protein in the urine, and 1+ blood, with occasional granular casts in the urine. His 24-hour urine collection has 8 grams of protein. That is a lot. And his creatinine clearance is 92 mils per minute. We haven't done creatinine clearance. For creatinine clearance, read his glomerular filtration rate, okay? It's pretty close. Blood studies show no evidence of diabetes or lupus. A cystoscopy, flat plate of the abdomen, and CT scan reveal no masses, stones, bladder problems, or prostate problems. So, my first question, does the patient have renal failure? It's a trick question. So, his GFR is 92 mils per minute. And that ain't too shabby for a 62-year-old. Okay? So his GFR is well maintained. Does he have any issues? Gosh, yes. He shouldn't be pouring out that much protein in his urine. And perhaps this also helps to illustrate why we changed our definitions of acute renal failure, chronic renal failure, and changed it to chronic kidney disease. This guy clearly has chronic kidney disease. Well, I assume it's a chronic condition, okay? It likely is a chronic condition. Assuming that this has been ongoing, he clearly has a chronic kidney disease, but he doesn't have a reduced GFR. And so he fits within the modern concept of chronic kidney disease, justifiably so. So, and I think somebody answered this question for me the other day. Why does the patient have edema? Wait a minute, where's my thing? Now you have to speak up. Yeah, I think you got it. It's still kind of quiet though. Hey, Morgan will give you training lessons.
I know.
She speaks louder. Yeah, so the protein loss in the urine is so profound that it's actually lowered, it's at this level it's likely to have lowered the plasma protein concentration. Okay, and remember, plasma proteins are the thing that reabsorb, the plasma proteins cause reabsorption of fluid from the interstitium back into the capillaries. Okay, so with reduced proteins, filtration tends to dominate reabsorption, and so you have edema. We'll come back to that case in just a little while. So we need to have ways of measuring protein. Now you can use a dipstick or measure turbidity and just get a protein concentration in the urine. And these, because these are fairly crude tests, they're listed down there on the right. You can get anything from 0 to a trace to 1+, 2+, 3+, 4+. And what did this patient have? 3+ protein, which is a lot. So even a trace is probably inappropriate. The one problem with measuring, and I don't need to write up the numbers, I think you can see those in the handout for yourself. The problem with this is what affects protein concentration, and again I'm thinking very simple now. Obviously protein. I thought I'd give you a clue. Obviously protein, what else? Volume, yeah, water, yeah. So give that gal a...
I have a lot.
What? Where'd they come from?
Upstairs.
I give up. Wow. Let's take a break. I'm going upstairs. I'm going to get some candies. Is that just for medical students? They won't. They'll let me. So now I've lost my train of thought. Oh yeah. So I mean, if I just drank 20 gallons of water, it would affect my urine protein concentration, right? So the issue with spot protein determinations is that it's highly dependent upon your hydration status, and so limited. I mean, if you catch something, then you're obviously going to follow it up, but it's not quantitatively very useful. So the next thing you can do is, and it's on the left, is you can actually collect urine for 24 hours and measure the total amount of protein that's produced